This program is brought to you by Emory University.
I'm Raghu Halkar. I'll be talking about role of nuclear medicine in GI emergency,
Just need you to speak a little louder, okay?
focusing on hepatobiliary and GI bleed imaging. Here is a good reference in Seminars of Nuclear Medicine published in 2013, giving a good comprehensive review of role of nuclear medicine in GI emergencies. Here are my disclosures. And quite often in the emergency room, you are encountered with right upper quadrant pain. And here are two studies showing that hepatobiliary imaging has a better accuracy when compared to ultrasound. Ultrasound in some situations can give very good accurate diagnosis. However, it is operator dependent. Another situation where nuclear imaging plays a bigger role in GI emergency is acute acalcular cholecystitis. 14% of all acute cholecystitis are acalcular, and they have a high mortality rate. And as you can see here, hepatobiliary imaging has a much better accuracy in detecting acute acalcular cholecystitis when compared to CT and ultrasound. Multiple radionuclides are used for imaging the liver, and it depends on which function of the liver you are going to harness for this imaging. If you want assessment of Kupffer cells or reticuloendothelial cells, we use technetium sulfur colloid. If you want to assess the functionality of hepatocyte and biliary system, we use immunodiastic acid, that is for hepatobiliary imaging. For hemangioma and for blood pool, we use RBC. For tumor infection localization, we use indium WBC or technetium ceratec WBC or gallium citrate. Nowadays, 18-FDG can be used to assess acute cholecystitis as well. Of course, it will be a more expensive way of detecting acute cholecystitis. So today we'll focus on immunodiastic acid and hepatobiliary imaging in the setting of GI emergencies. There are multiple different immunodiastic acids have been labeled with technetium 99M. As you can see, there is technetium mebrofenin, which has a better hepatic uptake and a much faster clearance when compared to disophenin, which has slightly lower hepatic uptake and longer T1 half. And you can see a small change in side chains can change disophenin to mebrofenin and make it more potent. Just completion's sake, radiation dosimetry, hepatobiliary imaging, the critical organ is large intestine. Usually we give around 5 to 8 millicurie of radiotracer for hepatobiliary imaging, and it gives about 1.9 rads to large intestine. The total body radiation is very minimal. However, because of this radiation, hepatobiliary imaging is contraindicated in pregnancy. Since it's a technetium labeled compound and technetium immunodiastic acid can get excreted in the milk, so if the patient is breastfeeding, we have to instruct the patient to stop breastfeeding for at least 24 hours. The preparations for hepatobiliary imaging is 4 hours of fasting. But if the patient is NPO for more than 24 hours or on hyperal, consider giving CCK and then perform HIDA scan. In case of acute abdomen at Emory University, we don't usually use CCK because it's a polypeptide and can have anaphylaxis, and patient can get more symptomatic. So usually instruct the referring physician to give a small fatty meal, and we wait for 4 hours. The reason to do this is if the patient is NPO or on hyperal, the usually gallbladder is distended and is filled with old non-radioactive bile, and the radioactive bile would not go into the gallbladder, and you will fail to visualize the gallbladder and may inadvertently call a false positive acute cholecystitis. If patient has received morphine, scan may show common bile duct stasis and may mimic like CBD obstruction. So it's important to know the history of whether the patient has received morphine or not. It's not a contraindication. We can still perform the study and give the correct diagnosis of acute cholecystitis or no acute cholecystitis. How the procedure is done? The patient usually receives anywhere between 5 to 8 millicurie of technetium immunodiastic acid intravenously. Dynamic images are acquired 1 minute per frame in a 128 by 128 matrix. The duration of the imaging is around 60 minutes. Our protocol requires that the technologists get a right lateral or LAO view, because this will help in separating the gallbladder from the common bile duct. And if the gallbladder is sitting on the common bile duct or close to the common bile duct, LAO view helps us to see the gallbladder much better, well separated from the common bile duct. If gallbladder is not visualized in the first 60 minutes, and if there is free flow of tracer to the gut, we give intravenous morphine 0.04 milligram per kilogram, usually about 2 milligram. We make sure the patient has no hypersensitivity for morphine or is not in respiratory depression. Then we again image for 30 minutes, and that will tell us whether this patient has acute cholecystitis or chronic cholecystitis. There is a good procedure guideline published in 2001 in the SNM website. Here is a composite image of every 5 minutes taken for 60 minutes and a normal hepatobiliary imaging. Within the first 5 minutes, most of the tracer is extracted by the hepatocytes, and within 10 minutes you can start seeing tracer coming into the common bile duct, and you can visualize the biliary tree. The tracer is within the gut within 15 to 20 minutes, and the gallbladder is visualized in 35 minutes. In this case, the gallbladder is well separated by common bile duct and the C loop of the duodenum. So this completes the study. However, in some cases where the gallbladder is sitting on the common bile duct or in close proximity to the C loop of the duodenum, doing a LAO view will separate the gallbladder from the common bile duct. And in the right lateral view, the gallbladder will be more located anteriorly. This is the anterior part of the abdomen, whereas the C loop of the duodenum will be more posterior. So LAO and right lateral views help to distinguish whether it's a gallbladder or what you are seeing is the tracer activity is in the C loop of the duodenum or common bile duct. Here is the dynamic imaging of a patient who has right upper quadrant pain, and ultrasound was equivocal. And I'll show the dynamic images. Again, as you can see, the gallbladder is seen filling very early in the study and fills very well. Of course, in this case, the gallbladder is also close to the common bile duct. And the left lateral view, right lateral view, or a LAO view will further help distinguishing whether it is gallbladder or common bile duct. In this case, it's rather straightforward. Another case, 60-year-old with right upper quadrant pain, and we did a 60-minute of image after giving technetium immunodiastic acid, and we didn't see the gallbladder, and there was free flow of tracer into the small intestine. So we went ahead and gave 2 milligram of morphine intravenously and imaged for another 30 minutes. And here you can see that the gallbladder is filling very well. This rules out cystic duct obstruction, saying that there is no acute cholecystitis. In hepatobiliary imaging, what we evaluate is whether the cystic duct is patent or not. And a closed cystic duct or obstructed cystic duct in our study equates to acute cholecystitis. An open cystic duct or a patent cystic duct will rule out acute cholecystitis. This case, there is a delayed gallbladder filling, and it fills only after giving morphine and this would amount to chronic cholecystitis. But there is no evidence of acute cholecystitis in this case. In contrast to the previous case, this is a patient again having right upper quadrant pain, and ultrasound was equivocal and requested to get a HIDA scan. And you can see here in the first 60 minutes, we don't see the gallbladder. There is free flow of tracer into the gut. Then we go ahead and give 2 milligram of IV morphine and image for another 30 minutes. And even after that 30 minutes, we don't see any tracer into the gallbladder fossa, showing that the cystic duct is obstructed. Hence, there is acute cholecystitis. As you can see, the intensity of the liver activity has changed in the post-morphine image because most of the tracer has gone into the gut. So quite often, when the tracer activity in the liver has gone down, we may give an additional dose of 2 millicurie of technetium immunodiazolic acid along with morphine to increase the tracer activity in the liver and to make it fill the gallbladder very well. And most of our technologists are aware of it, and usually in the department we do have 2 millicurie of spare technetium immunodiazolic after giving the first dose of 5 to 6 millicurie. Here is a different scenario. Patient with history of follicular B-cell lymphoma. There is a portahepatis lymph node in CT, and patient has jaundice and right upper quadrant pain. Classically, patients with acute cholecystitis rarely present with jaundice. If they present with jaundice, it's a case of Meritzi syndrome. Let us see how does this case look like. Throughout the 60 minutes of imaging after giving immunodiazolic acid, we don't see the biliary tree, we don't see tracer in the common bile duct, we don't see any tracer into the gut. We do some tracer uptake in the abdomen here on the left side. This is most probably in the kidneys. When the liver function is poor, there is vicarious excretion of immunodiazolic acid in the kidney, and there is no visualization of the gallbladder. So what will you do now? Do you give morphine? Do you give CCK? Say it's an inconclusive study, or do you do delayed images? There is no point in giving morphine because there is no tracer into the biliary tree. Because morphine usually causes sphincterophotic contraction, and if there is tracer in the biliary tree, it pushes the tracer into the cystic duct and into the gallbladder. In this case, morphine would not work. Giving CCK will not help because the patient has no tracer into the gallbladder at all. Is it an inconclusive study? No, it is not. We can do delayed images and get some information. This is a picture, what we call it as persistent hepatogram. And in this persistent hepatogram images, the differential diagnosis are either it is poor liver function, or cholestatic jaundice, or acute cholangitis. Here we did a 24-hour delayed images. We see tracer into the urinary bladder. There is tracer left in the liver, and you can see the gallbladder uptake. So this patient didn't have acute cholecystitis. This was more of a cholestatic jaundice or high-grade obstruction due to portahepatis node. What are the causes for non-visualization of the gallbladder? Of course, the most common cause is cystic duct obstruction leading to acute cholecystitis. Of course, we can get non-visualization of the gallbladder if patient has not given the correct history and has ingested food just before the study. So it's a must to have 4 hours of fasting. Prolonged NPO, as we stated earlier, more than 24 hours of not eating food can cause non-visualization of the gallbladder by distended gallbladder with old bile. In such cases, we usually give a fatty meal, wait 4 hours, and perform the study. Chronic illness can also cause non-visualization of the gallbladder. And in chronic illness, even after giving morphine, you may not see gallbladder. So once in a while, suggesting a 24-hour delayed images are helpful. Here is a patient again having right upper quadrant pain and no gallstones by ultrasound and equivocal findings in ultrasound, he was asked to get a HIDA scan. And as you can see here, there is tracer coming into the common bile duct and tracer is going into the intestine, but there is non-visualization of the gallbladder. There is a thin rim of increased activity near the gallbladder fossa. Post-morphine, that activity becomes more intense, but this is not gallbladder. This is what is called as rim sign. A tracer accumulates around the gallbladder fossa in the hepatocytes because there is inflammation, and those hepatocytes are unable to throw the radiotracer into the biliary system. So rim sign is seen by persistent increased uptake of tracer in the hepatocytes in the gallbladder fossa, and it is caused by increased hyperemia and inflammation around the gallbladder. Quite often, this is a indication of gangrenous gallbladder. So when you see a rim sign, there is a high specificity for acute cholecystitis. Very rarely in the emergency room, a patient may come back after cholecystectomy, basically to assess for leak. And here is a case wherein patient had cholecystectomy a week earlier and has leak. Usually there is no tracer in the gallbladder because the gallbladder has been removed, and the tracer usually goes into the paracolic gutter. If there is a post-cholecystectomy leak or a post-partial hepatectomy leak, most of the time the tracer goes into the paracolic gutter, or it goes along the superior surface of the liver under the diaphragm, or it can go to the lesser sac. So these are the three common areas where the tracer accumulates if there is a presence of leak. Many times the surgeons after hepatectomy wants to know whether there is free flow of tracer in the common bile duct and to the C loop of the duodenum, because if there is a minor leak but if the CBD is totally patent, the minor leak will heal by itself. If there is obstruction to the common bile duct, the leak will not heal. So in your report, it is also advisable to see whether there is tracer seen in the common bile duct and in the small intestine. That will help the surgeon for further management. Here is another case of leak wherein you can see the tracer is gone into the paracolic gutter, and don't get confused this with a tracer getting into the loop of bowel. Actually, the loop of bowel are photopenic and the loop of bowel are floating in a sea of radiotracer here. And there is tracer in the gallbladder fossa. So the cystic duct was most probably not tied correctly. So there was tracer in the gallbladder fossa and in the peritoneal cavity. Occasionally, you may see tracer going into the stomach, especially after morphine. And in this case, you can see the gallbladder is well visualized. There is free flow of tracer into the small intestine, but the tracer is going into the stomach. And this is enterogastric reflux. And in quite a few patients, we see enterogastric reflux, and it's an incidental finding which can be mentioned in the report. This is a patient who had received morphine before hepatobiliary imaging. That's why you see common bile duct, but no tracer going into the small intestine. You see the gallbladder. This rules out acute cholecystitis, but raises a possibility: is there common bile duct obstruction? But if you know the history that the patient has received morphine before HIDA, we will not have any problem to say that this is due to morphine effect and not due to CBD obstruction. And this patient didn't have raised bilirubin, or in the ultrasound there was no dilated common bile duct. When to use CCK? At Emory, we do not use CCK in acute cholecystitis only when chronic acalcular cholecystitis is suspected in a cold case and we want to assess gallbladder ejection fraction. We sometimes use CCK. But even in this situation, we more often use Boost or Ensure or a fatty meal to assess the gallbladder ejection fraction. So let us switch gears now and move on to GI bleed. And these slides, a few slides will tell about the causes and epidemiology of GI bleed, which most of you are very sure of. Gastrointestinal bleeding is about 8% of all emergency admission. This is an UK statistics showing that there are 6,000 annual deaths due to GI bleed. 80 to 85% of our upper GI bleed and are accessible to endoscopy. So 85% of the GI bleed stop spontaneously. 15% are highest for risk and need intervention. History and clinical exam can suggest a site of bleed only in 40%. So we need tools and techniques to decide where is the site of the bleed. In terms of presenting symptoms and management, quite often GI bleed presents as anemia, low hemoglobin, low BP or shock, and most of the patients would need blood transfusions. So if there is loss of 30% of blood volume in 24 hours, in spite of replenishing with blood, that's an indication to surgery. And that's the time when we would like to localize the GI bleed. The point I want to make is a little bit of blood loss or a melena should not be an emergency reason to do a GI bleed study. Radionuclide GI bleed studies are more suited for lower GI. For upper GI, the causes are peptic ulcer disease and variceal bleeding, and these are best handled by endoscopy or best located by endoscopic exam. Whereas lower GI bleeds are not usually amenable to endoscopy, and most of the lower GI bleed are intermittent bleeders. So at the time of endoscopy, you may not see the bleed, but the patient may be still bleeding. And the most common causes are colonic diverticular, angiodysplasia in small intestine, trauma or post-surgical. Recently, Kaposi sarcoma of the small intestine has also increased in number in terms of as a cause for lower GI bleed. Occult GI bleed is like looking for a needle in the haystack, and usually we do not use radionuclide technique to look for occult GI bleed. Once in a while we may do for a Meckel study. Radionuclide methods to localize GI bleed, there are multiple tracers have been used, but the one which we are using is technetium RBC. In GI bleed imaging, we label patients' RBC and re-inject them back. And nowadays we use UltraTag kit, which is an in vitro labeling and gives an excellent efficiency of labeling of RBCs with technetium. And the hallmark of GI bleed is movement of the accumulated tracer is a must. Movement can be antegrade or retrograde. And here is a case of patient with bright blood per rectum, drop in hematocrit even after blood transfusion. And the patient's RBCs were labeled with technetium pertechnetate, and about 20 to 25 millicurie is usually used for injection. And we image continuously dynamically for 60 minutes, 1 minute per frame. And as you can, we do a dynamic study of blood flow, 1 second per frame for 60 seconds, then 1 minute per frame for the rest 59 minutes. And here is the study. You can see, since it's technetium RBC, it's located in the intravascular pool. You can see the major vessels, the aorta and the IVC. There is tracer in the liver and spleen. And you can see the tracer has extravasated in the center part of the abdomen, and it moves very quickly and rapidly and changes in its intensity varyingly. This is a hallmark of small intestinal bleed. Fast moving, central location, and changing intensity is a classical sign of small intestinal bleed. So here we have not only said that is acute GI bleed, but also have located that it is in the small intestine. And the patient underwent an angiogram, and you can see there is a blush over here, and there was the GI bleed, and the patient, they coiled the bleeding site, and then it was found to be surgically removed, and it was found to be a small bowel gist. In contrast to small intestinal bleed, a large intestinal bleed usually is in the periphery, and where the ascending colon and the transfer of the descending colon comes, and it's slow to move, and in good cases you may see haustration marks. Here is a good example of a large intestinal bleed, and here the bleed is most probably in the splenic flexure, and you can see the bleed has moved both antegrade and retrograde, and you can see haustration signs in this descending colon and in the transverse colon. This is the patient. As you can very well see, that there is intense tracer activity in the mid of the abdomen, but throughout the study it is not moving, it is not changing in intensity. This is a case of abdominal aortic aneurysm. However, if you carefully look at the right upper quadrant, you will see a small area of changing intensity over here, and that was a small colonic diverticular bleed. So when there is intense uptake in the abdomen, you may miss a small focus of bleed, and this area changes in intensity, whereas this area doesn't change in intensity, telling that this is an aortic aneurysm and not a bleed, whereas this is a source of a bleed. In contrast to the last case, this is a subtle case of GI bleed. In this case, what is the problem and what will we do next? There is, I told that changing intensity and movement are hallmarks of GI bleed signs in radionuclide GI bleed studies. And here you see that there is tracer is moving and changing in intensity in the mid-abdomen. But there is an intense area of uptake over here. And here is the spleen, here is the right ventricle, left ventricle. This tracer uptake is in the stomach. And as you can see, this tracer uptake is there from starting point. So this is probably improper labeling of RBC, poor labeling of RBC, and there is free technetium in the stomach. And that free technetium is moving into the jejunum and small intestine. So this is not a true GI bleed, and usually we do not do GI bleed studies for upper GI, as I told you earlier, that upper GI bleeds can be handled by endoscopy. And in this case, one way to sort it out is to do a image of the neck. If there is uptake in the thyroid and in the salivary glands and in the mouth, that shows there was free technetium in the tracer injected, and that's why we got that lot of activity in the stomach. Are there any use for delayed images? The study in 1994 showed there is no use for delayed images. Results are more reliable when the scan is positive within the first 2 hours. So if the scan is negative for 60 minutes, and if the technologist and the camera time is available, go ahead and ask for 1 more hour of imaging rather than asking the patient to come for 24-hour delayed images. Here is a case to prove that point. This was early images. We didn't see the GI bleed. We asked the patient to come after 24 hours. We see tracer in the ascending colon and the transverse colon, but the angiogram did not show any uptake, or didn't show any site of bleed. And this bleed might have occurred anywhere between the first hour and the 24-hour, anywhere in the abdomen, and the tracer might have moved to the large intestine. So delayed images sometimes may give wrong sites of GI bleed, unless in the delayed images, to start with it was negative, and during the delayed imaging time, if the tracer activity appears, then we can pinpoint the GI bleed. Causes for false positive study: vascular uptake, hemangioma, genital and uterine uptake, renal and ureteric uptake, and as you saw the case of free technetium, in that case you check the thyroid area. Here is a case. These are every 5 minutes summed images, and total 12 images for 60 minutes. And you see some tracer activity in the lower abdomen, and there is some changing intensity over here. This is a patient with an indwelling catheter, and this uptake is due to penile uptake. Penile uptake is very common in men and should not be confused for a source of GI bleed. In this case, there is an incidental finding of photopenia around the liver in the right upper quadrant. You can see area of photopenia. This patient didn't have bright red blood per rectum, but he had dropped hematocrit significantly, and they were thinking of GI bleed as a reason for drop in hematocrit. And we looked at the CT scan done. The patient had a previous liver biopsy and had developed a large hematoma in the abdomen, and that was the source of his drop in hematocrit, and we can see that here. This is a case of a patient who is cirrhotic, and this is canalized umbilical vein, a vascular uptake which doesn't change during the study, remains the same. So this is not a GI bleed site. A persistent tracer uptake without movement and without changing the intensity is in favor of a vascular uptake. How good is radionuclide technique? It's pretty good, and as you can see, as long as you can image longer period of time, you can always find the site of the GI bleed. And as I can tell, the strength of GI bleed study with radionuclide study is because of the long intravascular T1/2 of the tracer. Technetium RBC can stay in the blood pool for more than 24 hours, whereas contrast studies, when we do angiography, they have a short contrast materials have a very short T1/2 in the intravascular pool. Unless the patient is bleeding while we are squirting the contrast, then only we can see the site of the GI bleed. Whereas in radionuclide study, because of our long intravascular T1/2, we have a window of seeing the GI bleed site for up to 24 hours if we can image all that duration. In terms of dosimetry, technetium RBC, if you use, it gives the critical organ is heart, and it gives 0.05 rads per millicurie. We may inject about 20 to 30 millicurie of labeled RBCs for GI bleed study. And that's the end of the talk.
The preceding program is copyrighted by Emory University.